To be here, delighted that we have such a great turnout. I'm going to cover the topic of new treatments. We now do have some new treatments to talk about, as well as something of the clinical trial landscape for Alzheimer's disease. So we do have a new form of treatment, and this was the announcement last year. The FDA converted treatment with an antibody called lecanemab to a full regular approval, and I'll talk a little bit about that, but it followed a trial that verified that there was a clinical benefit. But before we go there, a little bit about diagnosis. So you've heard a lot about doing scans and doing an autopsy examination of the brain to find out what's there. And we used to say that Alzheimer's disease can only be diagnosed at autopsy. Unfortunately, Professor Alzheimer, this is no longer true. We can now use biomarkers. We can do brain imaging, or we can do a lumbar puncture, obtain some spinal fluid, and we're getting pretty close to being able to do blood tests to identify the presence of plaques and tangles during life. So what we're trying to do, Dr. Brewer showed a complicated map of all of the different things that are going on in the brain and the timeline and so forth. We're trying to come up with three important aspects of Alzheimer's disease. One is amyloid, which is the plaques that are laid down in the brain. One is tau, or tangles. So these are what tangles look like under a microscope. They are within nerve cells, and a molecule called tau forms aggregates and clumps. And then the brain reacts in a way where if this was a brain of somebody who passed at a stage where they had completely intact cognition compared to someone with Alzheimer's, in Alzheimer's there has been loss of nerve cells and their connections, so you can see the grooves are kind of much, much deeper, and the brain actually weighs less, and that's the result of what we call neurodegeneration. So in the best of all worlds, we don't want to wait. We want to be able to detect some of these changes during life. So for the A for amyloid, Dr. Brewer showed a picture of what an amyloid PET scan can look like. We can also measure these amyloid molecules called amyloid beta protein, and we measure a ratio in either CSF or plasma. For tau, we can do a PET scan, and we're trying to develop some tau markers that can be measured in CSF or blood. It turns out most of them really relate to some changes that result from amyloid, but we're getting a little bit closer. And then for neurodegeneration, there's actually an embarrassment of riches of biomarkers. We can detect this brain shrinkage during life by doing an MRI, or we can do a different kind of PET scan, a glucose PET scan. Areas of the brain that are not working properly don't use glucose as well as they should. Or we can do a number of different biochemical tests. We can measure a different form of tau, a protein called neurofilament light, and other things. And so people have been working on this and putting this all together, and there's a framework now called ATN, amyloid, tau, and neurodegeneration. And if you look at all of the different pathologies that might contribute to memory loss or other kinds of cognitive change, it gets complicated, especially as people develop problems like this later in life. There may be more than one problem at play. So we think of Alzheimer's pathological changes, and you can have some Alzheimer's pathology and be cognitively completely normal. You can have Alzheimer's disease. You could have Alzheimer's together with other non-Alzheimer's brain pathologies, and then you could have non-Alzheimer's brain pathologies on their own. And three of the most important of these are alpha-synuclein, which is a molecule that builds up in Lewy body diseases, a molecule with the horrible name of TDP-43, which is very unmemorable until you've heard about it in a couple of thousand talks, and this builds up in nerve cells in a couple of different disorders, but also in some people in their 80s and 90s. And then something that we should be able to do more about, which is vascular changes in the brain, the results of things like getting older, but also high blood pressure, diabetes, heart disease, and so forth. And so all of this is going on, and there's some relationship between one or more of these with normal cognition. People can tolerate some of these changes. Subtle cognitive decline, which is one of the earliest changes we can find, mild cognitive impairment, an early stage, and then dementia. So getting on to some of the biomarkers, there are two tests that have been FDA approved, and this is to detect biomarkers in cerebrospinal fluid, and the companies involved have developed devices and fully automated machines where you pop in the sample, go and have coffee, and it spits out the result. And these are very, very accurate. This is called an ROC analysis, and perfect accuracy of 100% means that this line will kind of look like that. They don't do badly, 0.944 and almost 95% accuracy for two different ratios. They're not 100% perfect, so there may be a little bit of wiggle room, and if they're very close to the borderline, we may end up saying we have to get an amyloid PET scan to be even more certain. So there are a host of different emerging blood tests, and again, they are based on trying to detect the same proteins that we can find in the cerebral spinal fluid, but this time drawing blood and trying to see if we can measure the same things. So we, in CSF, we can measure this amyloid beta protein, and we look at the ratio between 42 and 40. So far, the best of the tests in blood is done by a company called C2N, and what they have done is, this is what their data looks like if you look at people who had the absence of amyloid determined by a PET scan or the presence. You can see there are group differences, but there's quite a lot of overlap. They've developed a formula where they add in age and ApoE genotype, and this separates groups quite a bit better. There still is a murky gray area which accounts for at least 20% of people. So it's reasonable. However, it turns out that there are forms of tau that we were able to detect in CSF that we can also measure in plasma. There are different forms of tau and different tests, and so the test actually matters. Some methods are more sensitive than others. This is one study where they did a head-to-head comparison using blood from roughly 100 people, some of whom had no amyloid pathology, some of whom had some degrees of amyloid pathology. And there's a form of tau called p-tau217, and it formed the best in terms of predicting or ruling out people with MCI. The best test was one, again, offered by this company called C2N. This was another 217 test that came close, and some of the other tests didn't do quite as well. Again, we like to see this area under the curve being at least 0.8 or higher before we would think a test is useful. So that's a little bit about diagnostics, but we're beginning to apply these in a situation where we make decisions about treatment. So the big news is anti-amyloid immunotherapy, which translated means we give somebody an antibody into a vein. The antibody, some of it crosses over into your brain and binds to the amyloid that is depositing in plaques, and it helps to remove it from the brain. There are two antibodies. There's been a lot of research in this area, but there are two antibodies have had different degrees of FDA approval. Lecanemab is the first one that was fully approved. Donanemab is awaiting its final hearing. They're slightly different. Donanemab binds to some fibrils of amyloid and clears the amyloid from plaques, and there were positive clinical trials. I'll show you some of the data. It was approved in July, and around, I think, September, Medicare said that they would provide coverage for treatment. Donanemab binds to a different part of plaques, binds to insoluble amyloid and clears plaques, and again there were positive trials, and we're waiting to hear what the FDA finally thinks. In the trials, both antibodies slowed clinical progression. They didn't halt it completely or reverse it. Both were associated with an adverse event called ARIA, and I'll show you what ARIA is. And this resulted in a boxed warning from the FDA. That means that in the very fine print that you will hear about. What did we do? Oh, okay. So I'm going. I should tap something.
Wake it up.
Just to wake it up. Okay. So what is ARIA? ARIA is called amyloid-related imaging abnormality, which is a horrible name, but it means that it's something that we can see on an MRI, and the patient may be completely unaware of it. So there are two forms of ARIA. There's ARIA-E for ARIA with edema or inflammation, and then there's ARIA-H, which the H is short for hemorrhage. So ARIA-E, usually we see areas, this is a little bit bigger than average. Usually they can be quite a bit smaller. There's an abnormal signal. The brain should all be gray, and here there's this area where there's been a little bit of inflammation, and sometimes it'll just disappear all on its own. ARIA-H, there are little black spots. You can see them over there, and they're pretty tiny. And again, they're very small bleeds. Sometimes they can be bigger. And again, these are things that can come and go and can have absolutely no impact whatsoever. So most events are actually asymptomatic. Sometimes people can have symptoms. They can range across a whole spectrum: headache, nausea, confusion, dizziness. Very rarely, but important to talk about, things like strokes or seizures can happen. So how do we mitigate this? And this was done in all of the clinical trials, and it's also going to be done in clinic. We do a baseline MRI, and if somebody has more than 4 of these microbleeds, we don't offer treatment because the risk of getting another bleed is higher. There are some studies going on as to what's the best threshold for this, maybe 4 is being much too strict. And then we do safety MRIs at 2, 3, and 6 months. It turns out ARIA is most common early during treatment. For some reason, the brain sort of gets used to the antibodies or whatever, and we don't see it very commonly later on. So that is ARIA. So let's see what actually happened during the clinical trials. So lecanemab was given intravenously every 2 weeks for 18 months, or people got a placebo. Quite a large study, almost 900 in each group, and it slowed clinical progression. So this is what kind of happened across a number of different markers. Let me start with the first one. This is amyloid PET. So this is the placebo group where the amyloid burden was increased on average. Again, there's some scatter around all of this. It increased a little bit over 18 months, and here's treatment where on average it was markedly reduced, and beginning as early as 3 months, but increasing so that many people had a significant reduction and even clearance by 18 months. Here are a number of different ratings that we do, and in all of them, people on active treatment, shown in gold, did better than people on placebo, and there is separation. And there's a certain percentage, somewhere between about 27 and 37%, depending on the rating scale. All of these scales have a lot of variability to them, so it's among the average, there may be some people who did very much better and very much worse. And the question is, how much does this mean? I'll get back to this question shortly. What about side effects? So ARIA-E, again, this was with MRI monitoring, 12% of people A very small number, 2.8% of people were symptomatic. Usually they were very mild symptoms. ARIA-H, 8.9% of lecanemab, 7.8% of placebo. So the important thing here is that people with Alzheimer's actually develop microhemorrhages without anybody doing anything to them. These are a little bit of a part of the disease, and it gets exaggerated or accentuated as a result of treatment. We do know that ARIA is higher in people who are carriers of the ApoE4 variant. And a percentage of people with Alzheimer's have 2 copies of E4 called E4-E4, and you can see the percentages. The risks are dramatically higher in people who are E4-E4 carriers. How about donanemab, the one we're waiting to hear about? It also cleared amyloid, very similar trial design. There's a slight difference in that donanemab binds to a different part of the plaque, and once it's cleared the plaque, there's no reason to keep giving it, so treatment got stopped at a certain stage in a number of these folks. You can see the same kinds of patterns of treatment, slowing slightly bigger in terms of percentage, but we don't know if this is truly meaningful. This was actually about the same in this particular measure, the same in both studies. Cleared amyloid in about 80% by 76 weeks. They also looked at tau PET, and they found that they had a much bigger signal in people who had a low tau PET burden. So this is shown over here. These are people who had the lower tau PET burden, and this is everybody. So there's a bigger difference there than here. Suggests that maybe starting earlier or also measuring tau PET may help us to predict people who might do a little bit better. 1.6% rate of serious ARIA. So now we're dealing with lecanemab, which has a cute sounding name, maybe out of Star Wars, of leukemia. And it is now FDA approved, covered by Medicare. And so this has a number of implications. So if MDs who are out there, they may be general neurologists, geriatricians, internists, primary care doctors, they need to be able to recognize MCI or mild dementia to even begin to advance people into a possible pipeline of treatment. They need to have a little bit of knowledge about this to be able to have an initial discussion with patients. And at a subspecialty clinic like the one we have at our UCSD Memory Disorders Clinic, we need to handle referrals of appropriate people in a timely manner. We need to confirm a diagnosis using biomarkers. We don't want to offer this unless somebody has amyloid in their brain. And we need to discuss treatment and manage it appropriately. So what are we doing at UCSD? We have a lengthy discussion with anybody before we even get near offering treatment. Firstly, regarding the diagnosis, do they have MCI or mild Alzheimer's disease just based on pencil and paper tests? How would they like us to go ahead and confirm whether there's Alzheimer's present or absent? Treatment will require intravenous infusions every 2 weeks. Are people up for this? What is the cost? Lecanemab is costing $26,000 a year, and while there is Medicare coverage, the Medicare coverage may only be 80%. There may be co-payments needed for some of the diagnostic tests, and there are some potential risks of ARIA and infusion reactions. If somebody is interested and appropriate, we review the workup that they've had. We repeat whatever we need to, review some inclusion-exclusion criteria. For example, we don't offer treatment if people are on certain types of anticoagulants. If someone can't have an MRI, we're not going to be able to offer treatment. We obtain the biomarker confirmation. We obtain a baseline MRI that's in a very sensitive protocol so we can really look at microbleeds. We obtain ApoE genotyping, and if someone is an E4-E4, we'll have a very lengthy discussion about the higher risks before we would offer treatment. And then we go through all of this in detail with the patient and their family. If somebody starts treatment, we have a monitoring program, and this is listed over here. We tell people about symptoms that might reflect ARIA and that they may need to go to an ER if they're concerned. We have 3 safety MRIs lined up, and if we detect significant or symptomatic ARIA, we would hold treatment or maybe have to stop it altogether. And new initiation of anticoagulation or TPA treatment. This is a treatment given for people who are seen in an emergency room where an acute stroke is suspected. These may carry major risks of intracranial hemorrhage. If these are necessary, then people should stop Leqembi completely. So, is Leqembi worth it? It's out there. There's a huge debate going on. This paper actually just came out yesterday, so I'm giving you very current information, but there have been a lot of models and analyses to try and figure out, is this worth it? I'll show you some data from this particular modeling study. This was a European viewpoint. A number of Alzheimer's centers in Europe got together and wrote something, and what they said is people who could be eligible in 27 European Union countries would be counted as 5.4 million individuals. If they treated these folks at the same price tag of 26K, it would exceed 133 billion euros per year, and this would amount to over half of the total pharmaceutical expenditures in the European Union. So at the moment, Leqembi is not approved in any European Union country. I can't show you everything that went on under the hood in this study. This was a modeling study looking at what some of the cost and benefits might be if we compared different ways to do the diagnosis of Leqembi, different models of how long it was people were treated versus standard of care. Standard of care would be no treatment at all. And this model tried to model what might happen over 7 years. And the problem is this is kind of looking into the crystal ball rather than looking at absolute data. But they tried a number of different models and assumptions. What they found, they looked at different approaches to the diagnostic tests, and they found that given data they had available, CSF testing was the most effective test in terms of cost effectiveness compared to blood or amyloid PET. They thought that limiting treatment to people who were not E4 carriers would be more effective, mainly because of risk. There's also some hint that people who were E4 carriers had a lower benefit. And including all costs, they estimated that the payment for lecanemab should be $5,100 per year, which is quite a bit less than $26,000. Other studies have done different sorts of modeling and have estimated about $9,000 per year. So, we live in the medical healthcare system of the US, where implementing changes like this is extraordinarily difficult, but it's possible that with a number of studies of this nature, maybe force can be brought to bear on pharmaceutical companies when donanemab might get approved. Hopefully this will give us a bit more data to see if the companies will actually go into a bit of a price war. So that's kind of lecanemab. So just to show you that there are other data that were collected during the clinical trial. There are different ways of measuring quality of life, and nobody knows what the best scale is. This was an informant-based quality of, actually a study where the patients and the informants were asked about quality of life during the lecanemab trial. And what was interesting is there, I've shown you 20 and 30% differences. Here there's a 47 to 56% difference in terms of people's impressions of quality of life. So this may be capturing something we're not capturing with our pencil and paper tests. That is an interesting aspect of treatment. So having said all of that, we need to continue to develop new treatments for Alzheimer's disease. There are lots of things going on in the anti-amyloid landscape. Leqembi is being developed to be able to give it subcutaneously. There are some prevention trials of combinations. These prevention trials using lecanemab and combination trials combining an anti-amyloid and an anti-tau antibody has started in a particular group of people who have an autosomal dominant inherited form of Alzheimer's. In these folks, within their families, the onset of Alzheimer's can be as early as 30. There are new anti-amyloid antibodies that are being developed. There are studies of active immunization. Now that we know that there are great advances, for example, in the COVID vaccine, can we apply some of those to improve how we might vaccinate people to raise their own antibodies against amyloid? And then there are some other approaches to amyloid in different stages of clinical trial development. What about other things? So there's a very big landscape. Jeff Cummings collates all ongoing clinical trials and publishes these once a year. And this shows sort of like a dartboard. Towards the center are studies that are either in phase 2 or phase 3, which means that they have some chance of giving us a meaningful readout versus things that are very early phase development. And they're targeting all kinds of different pathways and processes that may be relevant to Alzheimer's. Dr. Brewer talked briefly about tau as a therapeutic target, and there are a couple of phase 2 or 3 trials that are testing firstly whether antibodies can block the spread of tau. These include giving an antibody intravenously and also trying to do active immunization. We believe that tau may spread from one nerve cell to another. The other thing Dr. Brewer mentioned is, can we lower tau using these things called antisense oligonucleotides? And he showed some data from one published study. Antibodies, so this is all of the different fragments of tau that we can identify in CSF. So if you're going to develop an antibody against some form of tau, which one do you pick? And several trials targeted some of these fragments and they didn't work. Now people are targeting fragments or pieces of tau around here, which seem to show benefit in animal models, and we shall see how they fare in humans. If we talk about antisense oligonucleotides, these are things that have to be given by an injection into the CSF space. Some of them cross over into the blood-brain barrier. They enter cells and they bind to RNA, and they cause the RNA to be degraded within the cells and less of the protein is made. And so we can try to do this in the brain using antisense oligonucleotides for tau, and this particular approach has been FDA approved for a couple of other diseases, namely spinal muscular atrophy, which is a devastating illness in children, a little bit like motor neuron disease or Lou Gehrig's disease, and it has had dramatic benefits. And also one particular form of ALS with a particular kind of mutation has shown some early benefit with ASOs. One of the other pieces of data that came up from this ASO study is that if you did repeated lumbar punctures, did you actually lower the amount of tau in CSF, which would be one measure of target engagement? And these were people who got placebo, and these were people who got different doses, and so yes, there was a lowering of tau in CSF. So we are about to be a site for the next phase of treatment in this ASO study for tau. Haven't talked yet about lifestyle and brain aging and cognition. Dr. Sunman will tell you a few more things about this, but it's an active area of study. If we think about lifestyle being good for you or bad for you, some of the good components might be things that we don't have that much control over, our development, our education, some things we can control, exercise, diet, and so forth. And some of the bad things. So we can't do much about the aging process, at least not yet. We're hoping to impact Alzheimer's. We can certainly do things about vascular disease. We can try to do things about some of these other factors that I've listed over here. And there have been a number of studies that have tried to put these things together in a package. There's a study that was started in 2011, and it took a few years to be published. It goes by this very long name that was shortened to FINGER, and I think that giving Alzheimer's the finger would be a very, very good thing to try and accomplish. Having said that, so what they did is a intervention that involved diet, exercise, vascular risk, and so forth. They tried to personalize it for people, and people were aged 60 to 77 based on a cardiovascular risk score, and over 2 years they showed some benefits on different kinds of cognitive testing, which is interesting. Does this sort of thing actually impact Alzheimer's disease rather than doing something to make your brain generally better? There's one published study that did this at some scale, and they looked at one of these blood tests, plasma p-tau 181. This was a 36-month study, and unfortunately they found no effect of intervention on longitudinal plasma p-tau. So these things may be improving brain reserve, improving brain health, but so far we don't believe that they're impacting Alzheimer's disease. So, in summary, I think I've presented a lot of information. I hope I can convince you that anti-amyloid antibodies can result in slowing of clinical progression in these early stages of mild cognitive impairment or early mild Alzheimer's disease. Leqembi is FDA and CMS approved. Donanemab is waiting its final hearing. The blood-based biomarkers are starting to have clinical rollout, and we hope to see this field accelerating. Additional clinical trials are targeting amyloid, some are targeting tau, and there's one combination study, and we'll see how well these fare. There's a very large pipeline of drugs in development, and as we get involved in these, or other places around San Diego do, we need people to volunteer to be participants. Lifestyle interventions do show some cognitive effects, but so far no clear impact on biomarkers, and there is progress and hope in Alzheimer's therapeutics. So I'll stop there, and thank you very much.